morning, everybody. I'm really sorry for the late arrival since I have to come from catch 2 flights into the car. Today's my topic is on a huge unmet need in breast cancer, triple negative breast cancer, and how are you going to identify disease which does not have conventionally does not have targets. So we are unraveling a large number of targets are coming up. And some of the targets are really good, some of them we are finding we are reaching at the end. So basically a targetless disease, but new targets are opening. Greetings from all right, and this is my temple city, and this is my place where I practice, Ramaswamy Medical College. Today's my topic will be on the introduction, the role of the triple negatives in the metastatic breast cancer, neoadjuvant, PCR as an endpoint in TNBCs, how to improve the PCR, and is there a role for an adjuvant after following a PCR? This is a very important one. What are the strategies if the patient achieved a PCR, or how to improve the survival by giving any adjuvant treatment, when more and more we are giving the whole thing in the neoadjuvant setting. With the classical case, this everybody will come across in the fact is 56-year-old female, a postmenopausal with a 3 to 3 centimeter lump in the breast, mobile axillary lymph node, IDCs, and as you can see in the CT scan, 3.9 to 3.2 centimeter mass with the mobile axillary lymph node, left arm was done, and histopathology showed invasive carcinoma PT2N0 M0. And triple negative, BRCA mutation negative, it's not detected. So this is what classically we see many of times in our OPD. This patient was treated with the standard conventional chemotherapy regimen, so fantastic followed with taxanes. Now we are in the era of platinum compounds also, but this patient was like exposed to 2-3 lines of chemotherapy. But eventually this patient landed up with the brain metastasis. That's what happens. That's what I told you. It's an huge unmet need. Triple negative, whatever may be the standard of patient underwent surgery, followed by 2-3 lines of chemotherapy, including a platinum compounds. Invariably, they land up with the brain metastasis. Eventually, the patients succumb to the disease. This is where our TNBCs are now. This is where we are trying to conquer those TNBCs, unlike a chart positive on the head to negative subsets which we have gained. TNBC accounts for 10 to 15, 17% of the Western populations. We have still more higher incidence of more than 20% of our patients are TNBCs. Younger populations, majority of grade tumors with high-grade ductal carcinomas. 3 to 5 years relapse patterns are very common. Short disease interval, increase in the visceral metastasis, especially the liver and the brain. And 46% of the patients do develop the brain metastasis in our case. We have tried with all the conventional chemotherapy with the response rate of around 30%, less than 30%. These would call it triple negative paradox. They may respond very well, but the 5-year survival rates are less than 30%. Even though we have a high armamentarium of conventional chemotherapy drugs are available, still we have huge unmet need. The response rates in the first line is 25 to 45%. Time to progression is very short time to progression. As the time to durations and the responsiveness decreases as we go along the chemotherapy lines. Now we are unraveling this. The TNBC is not a single disease, and a highly heterogeneous disease with various elements classifications. 2011 has came out with the 6 different intrinsic subtypes, like the BL1, the basal, which usually have a platinum sensitivity, and LAR, the luminal androgen receptor, as the audience was talking about, using the enzalutamide in the LAR, and the mesenchymal and the mesenchymal-like, and immune-associated item, which usually have high number of Ts and the TMBs, which have a good response to the immunotherapies. So it's not a single disease, it's a highly heterogeneous. These various markers are now popping up, with the various targets are now popping up, and it's very exciting to be in these era where this TNBC, which is considered to be a target, is one now showing up more and more targets are popping up. Basal like 1, 2, immunomodulatory, and mesenchymal and mesenchymal-like and layer androgen receptor luminal. And they have various mutations that are associated with these genomic profiling. And these are the mutations. Some of them are targetable, some of them are, we are finding that they are not so good. So this is a very interesting one. Now we see the metastatic one. People have moved from conventional chemotherapy to targeted agents towards immune checkpoint inhibition in TNBC. The rationale is, out of all the breast cancers, we know that the TNBC is one which we have a higher amount of TILs and the PD-L1 expressions and the tumor mutation burdens are high. So they respond to immunotherapies, right? But unfortunately, the monotherapy with the immunotherapies, the response are less than 30%. We need a combination, we need a backbone of chemo. So immunocombo combinations are the one which will have a better response rate when compared to monotherapy. There are enriching for the monotherapy responses. You know, we need a robust biomarker to identify which are the subset of the patients who will respond to your immunotherapy. Out of that, the TILs and the PD-L1s and the TMBs, out of the TMBs and the TILs are the more robust markers when compared to the PD-L1. As you can see, they respond to the patients who are expressing their higher amount of TIL, higher amount of TMBs are going to respond very well when compared to the PD-L1 as not as a great robust markers. As you can see, any TNBC which is going to express more than 10 mutations per base, more than 10 are going to have a better response rate when compared to less than 10 mutations. This is the landmark studies IM Passion 130, where atezolizumab plus the chemo combinations is the backbone of the chemo. The chemo immuno combination of atezolizumab plus nab-paclitaxel compared to the nab-paclitaxel alone without the immuno are showing a better response rate as a ratio of 0.6 and the 3-year overall survival is 22% and compared to 36% of the combination of immuno and chemo combination. This is Keynote 355 where once again a pembrolizumab plus chemo is compared to the placebo plus chemo. Once again showing the pembro plus chemo scoring 35 versus 46.9% of the 6 months and 1 year survival rate of 39. PFS of 39.1 versus 23. And we have the ADCs now. We have moved. We know now the better way to deliver the chemotherapy, the more precision way. And these ADCs, the Acentral, the Sacituzumab govitecan versus the physician choice of single agent chemotherapy, has shown that these SGS in the patient even with the brain mets scores a better survival rate when compared to the physician choice of treatment. Overall survival also showing a better overall survival. 12.1 months versus 6.7 months. And when compared to when we have found that these targeted agents of the immunotherapies and ADCs are doing far better in the metastatic setting, they have been pushed to the neoadjuvant setting where the PCR, as you all know, the 80 patients who have been exposed to neoadjuvant chemotherapy, the PCR is a very robust endpoint. Anybody who is achieving the PCR will have better survival compared to non-achievers of PCR. When compared to the RCBs, the residual cancer burden, when compared to the TNBC with other outcome, anybody who has got an RCB will have a poor survival compared to no residual cancer burden. So exactly like TNB also, any patient who has RCB will survive poor, will be surviving very poor when compared to no RCB. So the TNBC's response to neoadjuvant compared similar to the non-TNBCs. The immunotherapies works far better when compared to the metastatic setting. It works far better in the neoadjuvant setting. Why? Because it has got the neoadjuvant setting. The tumor presents higher amount of antigens, more amount of neoantigens present. Tumor clonality is less, inter-tumor heterogeneity is less. The amount of expression of TIL, CD8 and DCs are high. PD-L1 positivity is high. Interferon signaling is high. So if you are able to use the immunotherapy in the neoadjuvant setting, it has got far more response when compared to the metastatic setting, which has got a lower amount of antigen presentation, higher tumor clonality, and higher amount of inter-tumor heterogeneity. So, if you are using immunotherapy along with the chemotherapy combo, it disrupts the tumor architecture, results in antigen shedding, induces rapid disease control. This is the very important randomization, adaptive randomization, where IS-2, an adaptive randomized phase 2 platform trial, where Paclitaxel plus the combination of chemo plus immuno, followed by an AC, is followed by surgery, is comparison with the chemo alone, shows that the PCR rate in the TNBC is very high if you're using a combination of immuno and chemo when compared to chemo alone. This is once again a geopolitical where the double-blind phase 2 trial of neoadjuvant durvalumab for 2 weeks, followed by durvalumab plus combination of chemo, followed by 8 weeks of conventional chemo plus AEC plus durvalumab, when compared to one and only the chemo arm, which shows that the PCR rate is 53.4 versus 44.2, and overall survival is 95.2 versus 83.5. This is another landmark study, the Keynote 522 study, where once again pembro, the chemo, is combined with the comparison with the chemo, immuno is compared with the chemo. The neoadjuvant as well as the adjuvant cycle also, we given 1 to 9 cycle of pembrolizumab is given, and it shows that the PCR rates are very high, and the PD-L1, depending upon the PD-L1 status also, the PD-L1 positive shows by higher response rates. PCR is showing a 64.8 versus 51.2%, and depending upon the PD-L1 status, it can go high up to 68.9%. And the event-free survival also 84.5 versus 76.8%. This is atezolizumab, the neoadjuvant setting. In the stage 2-3 TNBC, with a combination of chemo versus immuno, atezolizumab and nab-paclitaxel versus combination of one and only chemo, which once again shows the PCR rates are very high of 52%. At least you can achieve a PCR rate of 50% if you are combining an immuno with the chemo when compared to the chemo which has got less than 30% PCR rate in the case of TNBC. These are the 4 important landmark trials of the PCR rates in randomized TNBC neoadjuvant setting. Geopolitical durvalumab is combination with the standard arm of nab-paclitaxel. Neotriple PD-L1 is nab-paclitaxel plus carbo plus atezolizumab. In Keynote 522 is paclitaxel carbo plus pembrolizumab. IM-PASSION is 031 is nab-paclitaxel plus atezolizumab. So various combination of standard arm of nab-paclitaxel versus the different immunos, so gives you a PCR rate of around 50 to 60% when compared to less than 30% with the conventional chemotherapy. As we know that these patients may have a germline BRCA mutations positivity. If these patients, the TNBC patients showing a germline BRCA mutations positive, then PARP inhibitors are going to work. And the Olympia-IN trial on the ECOG, ACR, and it shows the neoadjuvant PARP inhibitors will standard of care chemotherapy in a germline BRCA mutation positive EBCs. These are ongoing trial. There is various upcoming neoadjuvant immunotherapy trial in early TNBC like SWAG to S221 alliance. SWAG S221 is neoadjuvant taxane carbo followed by AC plus pembrolizumab, dosi plus carbo plus pembrolizumab. These are all upcoming trials. And this is an ADC's phase 2 neostar where the sacituzumab govitecan in the localized TNBCs comparison with the chemo alone, it shows that the better response to PCR rates are there. These are all ongoing studies. Neoadjuvant talazoparib once again in the germline BRCA mutated positive patients, showing a 45.8% versus 49.2% by the intent to treat populations in the PCR rate, increase in the PCR rate. So, by adding a immunotherapy along with the chemotherapy in a TNBC subset, we are going to improve the PCR rates from 40 to less than 40 to around 50 to 60%. As we all know that the higher the amount of PCR rate, lesser the amount of RCPs, the survival is going to improve a lot. Is there any way to assess the MRD status? This is also phase 2 C-track TN. MRD directed therapy for moderate high risk early TNBC, where the ctDNA positive versus ctDNA negative was compared. Any patients who found to have a ctDNA positive were added, immunotherapies were added. When compared to the observation of the standard, when we have a ctDNA is negative, it shows that these ctDNA positives forms a very high risk after neoadjuvant therapy with the primary surgery as well as adjuvant chemotherapy. These patients are going to relapse very badly with the ctDNA positive, and if you are going to add immunotherapy in these subset of the patients, you are going to improve the survival. CTRAC-TN is the first clinical trial to prospectively assess the MRD-directed therapy in the early TNBC. 71.9% had overt metastatic disease on staging at the time of ctDNA. This is very important. Any patients who found to have ctDNA is going to recur very badly when compared with ctDNA negative following neoadjuvant chemotherapy and the standard of care of surgery and radiotherapy. So any patients who achieve a PCR around 50, we are going to improve the PCR rates around 50 to 60% with the chemo combos. What if the patient achieves CR with no residual cancer burden? Do they require, depending upon the molecular profile, do they require any kind of an adjuvant therapy? This is a very important question which needs to be answered. Adjuvant chemotherapy after PCR, when compared to the 5-year EFS in patients with PCR followed by an adjuvant chemotherapy without an adjuvant chemotherapy. Any patient who achieved a PCR where all the neoadjuvant chemotherapies are given, depending upon the molecular profile, there's not much difference if you add an adjuvant therapy, 86 to 88%, not much difference if you add chemotherapy alone. PCR is associated significantly improved EFS in both groups. There's no significant difference in hazard ratio between the two groups, between adding an adjuvant chemo versus no adjuvant chemos. But if you have an RCBs, you have a residual cancer burden, then definitely you have to add continuous 1 year of capecitabine. That's what the CREATE-X trial has shown. Any patient who is having an RCB will going to do badly. Any patient who has ctDNA is going to do badly. So this subset of the patient do require an adjuvant therapy, prolonged adjuvant therapy for more year or so for their capecitabine. This is what the CREATE-X trial has shown that. But if you have a germinate BRCA mutation positive, will adding a PARP inhibitor in the adjuvant setting following a standard of care of neoadjuvant on surgery, will it helpful? That's what Olympia trial has tried to answer that in the TNBC subgroup with the prior neoadjuvant and adjuvant treatment in the node positive T1 and T2 deletions. Adding our lab parameters comparison with the placebo, will it helpful in the finding of the invasive disease-free survival? 93.3 versus 88.4 in the TNBC's subset. Slight difference between the added advantage of adding an olaparib for unadjuvant setting for a neoadjuvant treatment. This is tropion breast post neoadjuvant Dato-DXT versus Durva, plus or minus Durva versus investigative choice of soil. These are ongoing trial. So, optimal adjuvant strategy for early TNBC. Right now we are using chemotherapy, but if you are going to use neoadjuvant IOs, will the adjuvant IOs also is required? Is the impact of adjuvant IOs if the patient is achieving an IPCR? There's no standard of care right now. We need a better biomarkers. We need to identify the subset of the patient who requires adjuvant if the patient is achieving a PCR. If not achieving PCR, then you have to give capecitabine or olaparib, whatever it is. And another important is de-escalation. The question of de-escalation comes. The patient is achieving a PCR. Do we need to identify a subset of the patients who may require a de-escalation in the neoadjuvant setting also? And is there any biomarker right now? We don't have that. And a lot of thought process on that, identify subset of the patients with the help of a biomarker like stromal TLs, which shows the stromal TLs and the survival outcome in TNBC following adjuvant chemotherapy. So they have done a study on identifying the mutation profile of the residual cancer burden. They did, as Kripa was talking about, they did a biopsy of the residual cancer burden, and they identified what are the markers which are being exposed in the residual cancer burden tumor, and which helps you in identifying these are the patients who are found to be resistant to your immuno and chemo and the upfront combinations. So these markers may help you to dictate which are the drugs which can be incorporated in the upfront itself. So the stromal TLs shows any patients who have got stromal TLs in a TNBCs, if positive, they have worse survival compared to a stromal TLs negatives. So this targetable molecular alteration, the residual breast cancer, which can be therapeutically identified and therapeutically altered in the neoadjuvant setting itself. These biomarkers are in the process, and we need to have those kind of biomarkers to identify these subset of the patients, which may be useful. This is what I talked about, the molecular discovery in drug-resistant residual TNBC after neoadjuvant chemotherapy. Any patient who has the basal-like tumors following a neoadjuvant immunocombinations or BRCA, whatever it is, depending upon the molecular profile, you are finding a residual cancer burden, and then you are doing a biopsy of that, and you find a basal-like markers. Then these are the patients who are going to do fairly bad when compared to non-basal-like markers. Mesenchymal, luminal AR, and BRCA1 activations are going to do far better when compared to the basal-like markers. And these will help you in identifying the neoadjuvant strategy, tailoring your neoadjuvant strategy. This is an algorithm which upcoming, and if you have a T1C and 0